The Mantoux test or Mendel-Mantoux test is a screening tool for tuberculosis. It is one of the major tuberculin skin tests used around the world, largely replacing multiple-puncture tests such as the Tine test. The Heaf test was used until 2005 in the UK, when it was replaced by the Mantoux test. It is endorsed by the American Thoracic Society and Centers for Disease Control and Prevention. It was also used in the USSR and is now prevalent in most of the former Soviet states. History: Tuberculin is a glycerol extract of the tubercle bacillus. Purified protein derivative tuberculin is a precipitate of species non-specific molecules obtained from filtrates of sterilized, concentrated cultures. The tuberculin reaction was first described by Robert Koch in 1890. The test was first developed and described by the German physician Felix Mendel in 1908. It is named after Charles Mantoux, a French physician who built on the work of Koch and Clemens von Pirquet to create his test in 1907. In 1939, M. A. Linecover in the USSR created a modified version of PPD. In 1954, the Soviet Union started mass production of PPDL, named after Linecover. Procedure: A standard dose is 5 tuberculin units tuberculin RT23 in 0.1 ml solution for injection. Is injected intradermally and read 48 to 72 hours later. This intradermal injection is termed the Mantoux technique. A person who has been exposed to the bacteria is expected to mount an immune response in the skin containing the bacterial proteins. The reaction is read by measuring the diameter of induration across the forearm in millimeters. If there is no induration, the result should be recorded as 0 millimeters. Erythema should not be measured. If a person has had a history of a positive tuberculin skin test, or had a recent tuberculin skin test, another skin test should be used. Classification of tuberculin reaction: the results of this test must be interpreted carefully. The person's medical risk factors determine at which increment of induration the result is considered positive. A positive result indicates TB exposure. 5 or more is positive in an HIV-positive person, persons with recent contacts with a terabyte patient, persons with nodular or fibrotic changes on chest X-ray consistent with old healed TB, patients with organ transplants, and other immunosuppressed patients. 10 or more is positive in recent arrivals from high-prevalence countries, injection drug users, residents and employees of high-risk congregate settings, mycobacteriology lab personnel, persons with clinical conditions that place them at high risk, children less than 4 years of age, or children and adolescents exposed to adults in high-risk categories. 15 or more is positive in persons with no known risk factors for TB. Note: targeted skin testing programs should only be conducted among high-risk groups. A tuberculin test conversion is defined as an increase of 10 or more within a 2-day period, regardless of age. Alternate criteria include increases of 6, 12, 15 or 18 False positive result: TST positive is measured by size of induration. The measurement of the induration is determined to be positive depending on risk factors. For example, a low-risk patient must have a larger induration for a positive than a high-risk patient. High-risk groups include recent contact, HIV, chest radiograph with fibrotic changes, organ transplant recipient, and immunosuppression. According to the Ohio Department of Health and U.S. Department of Health, the Bacillus calmette uruguayi copyright RIN vaccine does not protect against TB infection. It does, though, give 80% of children protection against tuberculous meningitis and miliary tuberculosis. Therefore, a positive TST-PPD in a person who received BCG vaccine is interpreted as latent TB infection. Due to the test's low specificity, most positive reactions in low-risk individuals are false positives. A false positive result may be caused by non-tuberculous mycobacteria or previous administration of BCG vaccine. Prior vaccination with BCG may result in a false positive result for many years afterwards. False positives can also occur when the injected area is touched, causing swelling and itching. Another source of false positive results can be from allergic reaction or hypersensitivity. Although rare, about 0.08 reported reactions per million doses of tuberculin, these reactions can be dangerous and precautions should be taken by having epinephrine available. False negative result: the result of PPD or tuberculin test is suppressed by the following conditions: infectious mononucleosis, live virus vaccine. The test should not be carried out within 3 weeks of live virus vaccination and should be rearranged. Sarcoidosis, Hodgkin's disease, corticosteroid therapy, steroid use, malnutrition, immunologically compromised, those on immunosuppressive treatment or those with HIV and low CD4 T cell counts, frequently show negative results from the PPD test. This is because the immune system needs to be functional to mount a response to the protein derivative injected under the skin. A false negative result may occur in a person who has been recently infected with TB, but whose immune system hasn't yet reacted to the bacteria. Upper respiratory virus infection: in case a second tuberculin test is necessary, it should be carried out in the other arm to avoid hypersensitizing the skin. BCG vaccine and the Mantoux test: the role of Mantoux testing in people who have been vaccinated is disputed. The U.S. recommends tuberculin skin testing is not contraindicated for BCG vaccinated persons, and prior BCG vaccination should not influence the interpretation of the test. The UK recommends interferon I-cube testing should be used to help interpret positive Mantoux tests, and serial tuberculin skin testing must not be done in people who have had prior BCG vaccinations. In general, the U.S. recommendation results in a much larger number of people being falsely diagnosed with latent tuberculosis, while the UK approach probably misses patients with latent tuberculosis who should be treated. According to the U.S. guidelines, latent tuberculosis infection diagnosis and treatment is considered for any BCG vaccinated person whose skin test is 10 or more greater, if any of these circumstances are present, was in contact with another person with infectious TB, was born or has lived in a high TB prevalence country, is continually exposed to populations where TB prevalence is high. Anergy testing: in cases of anergy, a lack of reaction by the body's defense mechanisms when it comes into contact with foreign substances, the tuberculin reaction will occur weakly, thus compromising the value of Mantoux testing. For example, anergy is present in AIDS, a disease which strongly depresses the immune system. Therefore, anergy testing is advised in cases where suspicion is warranted that it is present. However, routine anergy skin testing is not recommended. Two-step testing: some people who were previously infected with TB may have a negative reaction when tested years after infection, as the immune system response may gradually wane. This initial skin test, though negative, may stimulate the body's ability to react to tuberculin in future tests. Thus, a positive reaction to a subsequent test may be misinterpreted as a new infection, when in fact it is the result of a boosted reaction to an old infection. Use of two-step testing is recommended for initial skin testing of adults who will be retested periodically. This ensures any future positive tests can be interpreted as being caused by a new infection, rather than simply a reaction to an old infection. The first test is read 48 to 72 hours after injection. If the first test is positive, consider the person infected. If the first test is negative, give a second test 1 to 3 weeks after the first injection. The second test is read 48 to 72 hours after injection. If the second test is positive, consider the person previously infected. If the second test is negative, consider the person uninfected. A person who is diagnosed as infected on two-step testing is called a tuberculin reactor. The U.S. recommendation that prior BCG vaccination be ignored results in almost universal false diagnosis of tuberculosis infection in people who have had BCG. Recent developments: as a replacement for the Mantoux test, several other tests are being developed. The Quintiferon TB Gold blood test measures the patient-1 registered trademark S immune reactivity to the TB bacterium, and is useful for initial and serial testing of persons with an increased risk of latent or active tuberculosis infection. Guidelines for its use were released by the CDC in December 2005. Quintiferon TB Gold is FDA approved in the United States, has CE mark approval in Europe and has been approved by the MHLW in Japan. Heaf test. The Heaf tuberculin skin test was used in the United Kingdom, but discontinued in 2005. The equivalent Mantoux test positive levels done with 10 TUR, less than 5 ohm duration, 5 euro 15 ohm duration, greater than 15 ohm duration. See also, tuberculosis, latent tuberculosis, quintiferon, Tine test, references.